suction, what I want you to do is look and make sure your suction, and this happened to me, I want to say it was Tuesday. I don't think it was yesterday. It was Tuesday. No, it wasn't yesterday because I fixed it. My job is to check suction. I didn't check it. I've delegated this task at an outpatient center because people don't really grow up to somebody else, and they fumble, and it's my fault, and I owned it. When I say suction is working, I mean that little canister, the red canister that goes in these things, you'll see them at the bedside, that it's working, that the lid's down, that the port, that these things that connect the little, this is connected really well. I'm talking well. That this is connected down on that part that won't connect it. That this cord is long enough to get to my patient. That this is connected to my yawn car. That when I turn it on, that it's on max. That max actually works and it can suction. Because when you need suction, do you have time to wait? No. I found myself in an environment where suction wasn't working. People were, I didn't do my job. And when people didn't respond the way I wanted them to respond, with the level of precision and expedience and calm demeanor, when they didn't respond that way, I was thinking it was a good idea to blame them for being incompetent. That wasn't the issue. No one was incompetent. I mean, you could make the case, but that would have been the wrong case to make. The fact is, if I would have set suction up myself, it would have worked when I wanted it to work. I had a patient that I thought was probably aspirating. When suction wasn't working, I moved them over to on their stomach, and everything ended up fine. But I will tell you right now, be candid, I was pissed. This nurse is so incompetent. She couldn't connect this thing. She really couldn't. She's fumbled. She couldn't get out of the package.
Oh, no.
Why the patient's actively vomiting and asking, and I need the suction. And I'm thinking, why the hell didn't you have this set on? This is your job. And me and the surgeon are like, she's incompetent. And that wasn't a good place for me to be, right? It wasn't good. And she wasn't incompetent. And if I take full responsibility, which I'm doing, I should have checked suction was working. I should not delegate suction. In fact, pretty hypocritical, because I'm telling you guys, you better check suction. If not, you're going to fail your damn test. So it was good. Good learning lesson. When you need suction, you need it now. Don't just say suction's available. Don't just visually look at it. Don't delegate it to anybody. When you need it right now. Make sure that you check that all of this works. Okay? If it doesn't work, don't move on. This one works. Airway. Airway. I got this out. We'll replace that. When I say airway, I want all my airway stuff. I want 2 blades. Miller 2. Mac 3. This is exactly, and I'm serious, exactly how I want your airway set up. And OPAs, 80, 90, and 100. I'll let you take a picture. 80, 90, and 100 millimeter OPAs set up. Okay? Six O endotracheal tube. I got some stylettes. Reuse your stylettes, okay? This is your endotracheal tube. Take it out. Don't touch everything. Where do most disconnections happen in anesthesia?
The white piece.
White piece. This comes in, and it's just barely in, just like that. Do you see how easy it was to come out? This can happen very easy. So what I tell you guys to do is turn this 90 degrees. When I say 90 degrees, there's a radio-opaque line on every endotracheal tube. Turn this 90 degrees, this little ET tube connector deal, turn it and push this all the way in as far as you can go. Okay? It still comes out. But push it in, and if you need to, you can get this wet with like an alcohol swab, and you can hug this thing so that there's no disconnection there. So you have a 10 cc syringe. You're going to check your pilot cup. Connect that there. 10 cc's. How's my pilot cuff look? Do I know that it's not leaking?
Yeah.
No, I do not, because I'm still connected here. Take this off so that the valve is allowed to close. I say that because it's happened, but I've checked this on a robot case and I thought this was good. I didn't take this off, and this valve had a little stick in it. So take this off, check, and if you want to keep it safe for your patient. You can do this inside the bag, so you're not touching this and putting in their trachea. This is connected. Evacuate all of the air that's in that cuff. And then I'm taking out more to see this thing depressed. Why am I taking all of that out?
Make sure it's all out.
Not damaged.
Okay, damaged vocal cord just to make sure it's all out. What else? The main thing that I'm doing that is because when I go to intubate, I want to have the maximal vision when I'm intubating. If this cuff's all up, it's going to block my view. So I want this as slender and slim as I can to aid in visualization during laryngoscopy. So that is checked. Then I put loaded this with 10 cc's of air. I'm going to stylette my tube. Notice, I'm going to bend this 90 degrees. I'm going to bend this kind of like a hockey stick, just like that. See where this little hole is and where the end of the stylet is? The little hole?
Yeah.
What's that hole called?
Murphy's eye.
Murphy's eye. What's a Murphy's eye for? If you know, great. If you don't, I'll tell you.
Just in case it lodges into the wall of the trachea, you still have some.
Exactly right. Another good. You've been reading. That's good. So it's another. What Laveau said is, this Murphy's eye allows, if this intubates, goes in and sits anywhere on the lung. Let's say the carina, I can still ventilate the patient through another area. Okay. What you don't want to have is this stylet to go through and now become a weapon.
Right.
Okay. Either way. So right up to the Murphy's eye, the first hole, then bend down 90. Put it all this together. Right here. Now let's say you're, and I'm going to tell you this right now, and I'll repeat it again. We're going to do an LMA case. We're going to do a mass case. This will always be the way you set your airway up. If I'm doing a MAC anesthetic, monitored anesthesia care, a regional anesthetic, do I need laryngoscopes? Do I need a little endotracheal tube ready?
Just in case.
Why?
Stop breathing.
Maybe an LMA.
Just in case.
Because everything can, I mean, what's our backup plan? If something ever happens, we're going to become a general anesthetic. All patients may need it, so always have it available. Just like suction, you don't want these not available when you need them, okay? And that happens too. Make sure when you check your laryngoscope, and I didn't show you that, I said just get this, I assumed. I did it, you saw me do this. Make sure that your light's working. You ever looked in the mouth without a light? Probably not, but if you did, fine. It's really dark, okay, if these aren't working. So make sure these are working. Both of them are working. Make sure that they're here. You have your OPAs. My airway is ready, okay? That's what your airway is going to look like. You want to take a picture again? It says tongue blade. I don't have any, so you're not going to have one. If you have one, have it there. Why do I want a tongue blade? So you can move the tongue down and put an OPA in. Another way to do that, as long as you're mindful of the hard and soft palate, is you can put it in this way and turn. Still make sure you don't cut up and create a bloody airway, right? And then don't put it in this way and push the tongue back and occlude it. Okay, that's what a tongue blade's for. That's your airway. Okay? If your airway, so when you're doing this later on, we're doing an LMA, you set up this way, then you get your LMAs ready. When we're doing pediatrics, you'll do a little calculation to do a pediatric endotracheal tube. You'll also have a size above and a size below. For pediatric, if it's a cup, probably half a size above or below. But you're always ready. So that when you get in there and you're doing laryngoscopy and you see, well, they have tracheal stenosis, this tube won't fit. You immediately have your other one, okay? Or whatever reason. Does that make sense? 5 more minutes. Let's get through machine and monitors. Machine, you'll notice pre-anesthesia machine check. We've done that in that final little part at the end, which is, again, part of the machine check. We've done the whole thing. Vaporizers are on. No. Vaporizers are off. They're full. Everything's on. All flows are off. Suction is available. It says we're good to go. Now, this is connected here. Again, I say at the Y, if something happens, you're always tracing yourself back. When you see me and put these on, you'll see me push these things tight when I'm checking my circuit. So make sure these don't come off, because they do come off. Okay? Monitors. We'll get to that, but that your monitors are turned on, ready to go, and every monitor particularly that you're going to use. So our main monitors are going to be our EKG, our SpO2, our NIBP, be your CO2. All of these are connected. This would have a little defend, is a little contraption or your side stream diverter that it's connected to, that it's connected, working. All of that there is ready to go. If you were going to use a Biz monitor or a Vigileo or Artline, all of those monitors that you need are available, ready to go. Does that make sense? Okay. Yeah, precordial stethoscope and earpiece. So I'm going to get that with the E on SAMMTIDE, which is everything else, but it has it there even. Tape. I am a stickler about tape. So I want you to tape exactly the way I tape. And exactly the way I tape here, not the way you may see me tape in the operating room. When you set up your case, I want you to set it up just like this. Actually, this goes right here. Have these as damn near close to the same size as you can. Do not get sloppy. I'm serious. I'm putting tabs on both sides. So you will put tabs on both sides. Make your tape exactly this way. Exactly this way. You're all going to be tested on this. Okay?
What was the purpose of having the other side up? Well, I know it's for the AT2, but why?
So this sits right
I
in the
see.
maxilla, and this is ready to come up around my tube. Now we have to get more tape. This is messed up. This tape is expensive. Is that the little trash can over there?
Yeah.
Can you hand that to me? Please, thank you. Now, you may see me tape differently in the hospital, but tape this way. It's a good habit to get into, and it makes you look good, believe it or not, when you go out. It's probably not long enough, but oh well. I'm going to make it work for right now.
The other one.
Good, grasshoppers. Okay. Later on, you'll see that I say put the tape on your mask. Have you guys seen that yet? No? Shoot. You fail. Why do I have the tape on the mask? Where am I in what?
Tape that.
That's right. So when am I going to ever use a mask?
Induction.
Right before.
On induction, that's true. I'm going to have it up here. Okay. So I push my induction agents, then what do? Very next step.
Tape the eyes.
No. It's close. No, it's not. Maybe.
Check a
close.
lash reflex?
Check the lash reflex. Why am I checking?
Stage
Stage 3.
Okay, but why? Why do I care?
That's so you can intubate.
Okay, but before I intubate, what am I going to do? I'm going to get muscle relaxant. Before I get muscle relaxant, what am I going to do?
Ventilation.
Ventilation. So what I'm getting at is, before I do any airway manipulation, I want to make sure they're in stage 3, not stage 2. I'm going to check the lash reflex. So this is all around that time. Before I pick this mask up now to ventilate them, manually, I'm going to tape the eyes. Does that make sense? I'm getting out of order, but I'm just showing you why. Method to the madness. There's tabs there so you can at least get it off and it's just not waking up. We got let's use 2 more minutes. We'll get through all this. Are you guys okay if we get through all this real quick? All right, let's do it. That's what we're going to do. It doesn't matter if you're okay or not. That's what we're doing. So IV fluids and supplies. Make sure that you have a bag or a liter of ringers or saline in the room or with the patient ready to go with a working IV. Make sure that IV is working. Make sure that, I hate to say it, but sometimes the pre-op nurses aren't the best when they do their IVs. Sometimes they put a 24 gauge IV in the hand. Propofol in the hand burns, especially through a smaller lumen IV. We don't want that. But if it is working and we can make it work fine, make sure the IV is working, not infiltrated, flowing well. Make sure that you have 2 IV pulls in here. Why do I want 2 IV pulls? Drapes. Exactly. Ether screen. So we did that. Drugs. Syringes are prepared, ready to go. Right here, these are going to be your induction drugs that are in there, okay? Fentanyl, Versed, lidocaine, propofol, Sux, and Rocuron.
That's already special?
Yeah, I still use it. I don't use Rock, I use Sux and Beck. All that, one drug, one time, etc. Make sure that your apples or emergency drugs are here, ready to go. Make sure that they're separated, right, in one drawer, and we'll show you that in a second. And then finally, the E in SAMMTIDE is equipment. That's everything, or equipment or everything else. Forced air warmer or bear hugger, biz monitor, temperature monitor, peripheral nerve stimulator, arterial blood pressure, whatever else you're using that you're going to need for that case, and that changes. But make sure that you have that little nuance ready to go. Okay? Pretty straightforward. Then we're going to come back in here, every one of them. Here's what we're going to do for every single one of your group. You're going to go through your SAMMTIDE, and then we're going to go through the basic steps of an anesthetic induction. Fun. Okay, let me go get some coffee and we can do it.